Today, we'll be going through a differently entire topic, organizing of palliative care services. To walk us through the session, we have the very apt person, Ms. Arathy Venukumar, joining us for the evening. She is a postgraduate, MBA postgraduate with her specialization in HR and finance. And she is presently working as the national coordinator for the State Facilitation Department of Palliative India. With an extensive experience of around 10 years in the human resource management field, her special areas of interest are human resource management, palliative care, and project management. She is associated with Pallium India for the last 7 years in various profiles. So without wasting much time, I invite Ms. Arathy to walk us through the session. Ma'am, over to you.
Thank you, Sri Priya. Hello all, good evening. So, as introduced, I am Arathy, working as National Coordinator with the State Facilitation Division. I act as coordinator between Pallium India and the regional coordinators who work across India. Let me brief about State Facilitation Division. We as a division try to take the work that Pallium India does to various regions in India with a vision to facilitate access to palliative care to all those who are in need. Details will follow as we go through these slides. Now, this session, Organizing Palliative Care Services, will brief you about how you can open a palliative care center in your region. So you may be already a part of some hospital, or individually you may be having some clinics. We shall guide you on how to start a palliative care service in your setting. So please feel free to clarify any queries. We'll be happy to help. And in between, if you have any questions, you can drop text in the chat box. We'll clear it in the Q&A session at the last. So we'll start with this. This is called WHO Palliative Care Advocacy Triangle. As per WHO, to set up a successful palliative care center, we need to ensure three things: education, drug availability, policy, and implementation. So we'll start with education. There are barriers to palliative care which we'll have to overcome through education. So there is lack of awareness among the administrators, there is lack of awareness among the professionals, and there is lack of awareness among the public. So it is essential to educate the public, and public demand does persuade professionals and administrators to think. Next, coming to the drug availability, pain relief is the integral part in palliative care. So, and for that, availability and accessibility of pain relief drugs is necessary. So, as you all know, morphine is the mainstay of pain management. Its availability has been eased to some extent by this amendment of NDPS Act in 2014. But most of the states, as we see while working with them, are yet to implement those acts, so those amendments. Now, coming to the policy and implementation, in much of the world, palliative care came into being because of the individual initiatives and action by non-government organizations, NGOs. So, however, to achieve national coverage and palliative care, palliative care needs to be integrated into the general healthcare system, healthcare delivery system. Government action is also needed to remove barriers to access pain relievers. This is essential for this is essential for the budding services to develop their own policies that can overcome any gap in available facilities. So, as we now know that when we plan to open a palliative care services, we do well remember that you should be trained, you should have the opioids available, and there should be a policy or a program available to support your service. Hope I am clear to everyone till now. Okay to go forward? Yeah? Okay. So now we'll be briefing you about the organizing palliative care in Indian context. In Indian context, as you can see, that it's broadly classified into three major categories: standalone, a department within a hospital, and community-based home care. So a standalone model is an independent facility where we provide palliative care with specific focus on pain and symptom management. And along with that, we'll be focusing on improving quality of life of patients as well as their family. This can be done through a hospice or a palliative care center. Next, we'll come to the department wherein like there will be a department within a hospital. So it will be like a dedicated department for palliative care attached to an established hospital. This can be a government hospital, a charitable hospital, a sustainable model, or a for-profit model. Now coming to the community-based home care, this is wherein community gets involved. Here we reach to the care receiver where they are. So here the social capital acts as a bridge between the micro and the macro, and the major element of social capital are volunteers. So the micro macro elements details will be coming later in. This is just a brief that I'm going through. Now we'll see few standalone centers with whom we are working. You can see Cipla Palliative Care Center and Training Center. You can see Ruma Avedana Hospice. Cipla is in Pune, Ruma Avedana Hospice is in Kolkata. And we have Chandigarh Hospice. These are examples of standalone hospices wherein palliative care delivery happens. Next this is a palliative care unit which functions within a hospital. So this is a government hospital in Arunachal Pradesh. And we have our regional coordinator, Ron, with the team there. So that is Ron Sangma. He works as a regional coordinator with Palliative India, and he looks after the northeastern region. We'll come into the details later on. So this is just to explain the pictures. Now, the third category through which palliative care is delivered, as I told earlier, is through the community-based home care. The difference between regular home care services and community-based is the mode of delivery, the mode through which palliative care is delivered. So in Indian context, the macro components, that is the tertiary hospitals that you can see in the right side, they grow bigger and bigger with the services that they provide, and the micro component, that is the beneficiary, they are not able to reach them. There is a gap in between these two, and this is wherein the community concept comes into action, which we called it as meso component. Here they take the ownership of bringing the micro and the macro together, bridging the gap in between them. So now the Kerala state has utilized the power of community model, which might not work in the settings where you may belong to, but we would like to bring in to you as an example or a prototype with which you can get an idea how you can go forward with setting up a service, like setting up a palliative care service. Sorry. In Kerala, I'll just give a brief about Kerala model. In Kerala, we have more than 100 palliative care centers across the state. And this is because we have a state policy. Like I told you earlier that policy implementation is a major factor to run a successful palliative care center. So Kerala has a state policy for palliative care in place, which allows to have so many centers. So this was written in 2008, and then it was revised in 2019. This ensures that palliative care is integrated into the healthcare. So the basic units in Kerala, that is the panchayats, have palliative care units, which will have a doctor, a nurse, or maybe a social worker who will ensure that the palliative care is accessible to all in their area. Like panchayat are the smallest units in a state. So if their area is covered, so each panchayat will have their area covered with as accessible to palliative care. So this is what the government does. And in community model, it's like taking palliative care from where it is getting delivered. That's what, from the macro level, where it is getting delivered to the community, whosoever is in need, like to the micro. So from the macro to the micro, that's what the MISHO or the volunteers, community-based or community engagement means. So the community here in Kerala is well aware of their rights, and maybe that's why it is so interested. They are so interested to join in their hands together for the micro element of the society. The community factor itself played a major role to start Palliative India as well. So, like Dr. Raj, of course, was a trained professional in palliative care, but he had two volunteers who joined him, to be specific, non-medical people. And these two people joined him for the noble cause. So there was only one medical professional and two non-medicals working to set up a Palliative India. So that's how community engagement works. Now coming to a story, this is K.N. Nair. He's one of our oldest volunteer. He was now a 70-year gentleman. He's an ex-serviceman. He came into palliative care when his wife was diagnosed with cancer, and when she was beneficiary of Palliative India. So that's how he came into Palliative India. Now he was the primary caregiver of his wife. And when she died in 2004, from the point onwards, or after that, he became our volunteer. And as a volunteer, what he does, the magic, I would say, magic that he does to our patients is like everybody is his family member. That's what his concept is. That's what I can understand from his volunteerism. He knows each and every patient that he meets here as his on his fingertips. Like he has every detail of that patient. So he will go with our home care team here. Our home care team consists of a doctor, a nurse, and a social worker. That's the basic unit that we have. And he accompanies these people, and he visits each and every home in the city premises. He doesn't go anywhere else, only the city premises. So he was known for city home care. So he will be going to each and every home. He'll be assessing the patient maybe not on the medical part, the psychosocial element. You might have learned from the beginning that there are 4 aspects of palliative care, where psychosocial also comes into picture. So he takes care of that part. And the patients are so comfortable with him that if they have any problem, they would call him first, and then the team, like the doctors or the nurses whosoever the patient is seen by. So that's how a volunteer works in Palliative India. So you have to find such people in your locality, such passion in your locality. That's what the aim of this story was. So now coming into the crux of this session, how to organize a palliative care service. We just have jotted down 10-step approach. So this is a basic flow that we follow here in Palliative India. Not necessary that it should be the flow or these things should be considered while you set up a palliative care center. This should be the flow. No, it's not a concrete rule as such. It's just based on it is based on your settings. So it will be region specific. The flow that we follow will be region specific, but these all things have to be included. These things have to be there to start a palliative care center. Sorry. So now, first thing we'll go with the arrange funds. That's the thing that we have to have before starting any unit. So funds are the major part. So before starting to organize a whole program of palliative care service, we need to think from where we can arrange funds from. So if you are a part of government hospitals, then the funds are available through various programs like NPPC, Ayushman Bharat scheme and all. For private, of course, you will create a service and then you'll deliver it and then you'll charge for it. So that the fund part is taken care of there. And now for the real challenge lies with the charitable and the individual people. So they have to look for grants or public donations or CSR. So you should have an idea which source you'll be opting for before starting or getting into organizing palliative care services. You should have an idea about how will you go forward. So without funds, you won't be able to move forward. So that's the first thing. Now, recruiting a team. Of course, for delivering, you need a basic team. So it's another important aspect. And that should be a trained team. So now you are getting trained, a trained doctor is available. Now you will have to have a trained nurse and a trained social officer. So this constitutes a basic team, a doctor, a nurse, and a social officer. As forward, like going forward, when you grow, you'll have more team members into your team, like allied medical professionals called pharmacists, physiotherapists, occupational therapists, dietitians, etc. So moving forward, you will have to have these people in your team, but basic a unit consists of doctor, a nurse, and a social officer, and that too trained professionals. There are specific courses in palliative care, so we'll be talking about that later. Like you are trained right now, we have courses for nurses and social officers and other professionals also. So that's recruitment part. Now, next is infrastructure. Of course, for conducting minimum OP, you'll have to have a space where you put in a chair and an examination table or maybe a bed. So a space, maybe a small space, a room that would be required for an OP. For inpatient, of course, beds for treating the patients. For if you are looking for a long stay, inpatient unit will require a bed and other furnitures. And in case of home care, you will require a vehicle which can be used by the team to travel to the person who is in needy. And the team will consist of a doctor, a nurse, and a social officers. And you will carry the medicine and the consumables too. So you have to have a vehicle which can accommodate all these things. Now, procuring opioids. As I mentioned in the starting, that the triangle, you have to ensure the availability of the drugs. So for that, to procure, to store, to dispense opioids, you need to be a part of a recognized medical institution. It's a very important point. You have to have a license, RMI license, to procure, dispense, or store opioids. So there will be it's a very long topic. It's a very vast topic. There will be another session like this on opioid availability. So you will get more details through that session. It's just that keep in mind, whenever you are looking forward to open a center, you have to have RMI license. That's the thing. And of course, you need to establish connects with the existing experts in palliative care in your area. This will help you to understand the local challenges and the local support that is available. So you'll be able to work accordingly or put in your efforts accordingly. Next is you need to arrange awareness, like in the public, awareness, create awareness among the public, as well as your team. Maybe if you are attached for, attached with an established hospital, you can aware the team there also, so that this will help you to get referrals within the public as well as from your hospital, and and also identify local champions, like I told, like Nair uncle, like him, you can identify local champions who will be able to refer and take the word of the work that you do and in your center. uh, Next is developing OP, that I already mentioned, that you'll have to have a local hall, classroom, schools or colleges. Like we here have associate, we here are tie up with local schools or halls, like bank halls, or some space wherein we can conduct. Like with the government, we have a room in the Government Medical College Trivandrum. We have a room specifically dedicated for palliative care, OP. So we go there and conduct OP. So we'll have a room available there. So in other areas where, like in and around Trivandrum, we have few OPs that we conduct. So there also we have, at some places we have bank halls, we have parking areas of some institutions, or we have schools, classrooms. So whenever there are no schools on Saturdays, and we will get that room from, it's now free of cost. So we get space there to conduct an OP. So that's how OP works here. And just the thing that you need to ensure is that the facility that you are, hiring or taking for conducting an OP should be a disabled friendly space. So just keep in mind that it's a disabled. So if a patient comes on wheelchair, they don't feel like they are, restricted to enter the space. So just that things need to be ensured. Now, developing an inpatient facility, it will involve a lot more in infrastructure in terms of bed, like I told you earlier, beds for patients, side lockers, etc. So you all know better than me. You have been working in a hospital or would have a settings or access to such settings. So you all know what happens with, what all are needed to open a inpatient facility. For home care, as I said earlier, we'll have one vehicle which can accommodate a team of doctors, nurse, and a social officer, plus medicine and consumables, because we are taking the care to where they want. So we'll have to have all things that are needed in a patient care. So we'll take all things from the macro system to the micro level. So that's how it works here. And here, what we have to see is that there are scenarios that we have faced, like a doctor or a nurse go on their home, two-wheeler with the medicine bag. It would be just a handbag that they are using on the two-wheeler, and they go for home care. So that's also a situation that happens, and it's just a passion that drives your work. Drives the delivery. And involvement of volunteers, as of now, I think you would have got an idea how volunteers can be involved for our palliative care delivery. So now we'll look into how we support or facilitate palliative care services with already discussed models like government subsidized or sustainable model, or for-profit model, or a charitable model. First thing that we'll take care or we'll support, as in Pallium India will support, is the capacity building, wherein capacity building involves, we conduct workshops. We conduct orientation programs. This would be on-site or virtual, whichever is feasible for the stakeholder. We conduct foundation trainings, like what we are doing it now for you. We have foundation trainings for doctors. We have foundation training for nurses, health workers, and beyond that we do is conduct faculty, training for faculty for UG curriculum. Like we are in a process to involve palliative care into the curriculum, medical curriculum. So that's a process that we do. So we also train the faculty in palliative care to develop the UG curriculum. We have training and engagement programs for volunteers and the community. So we go into the community and train them. And we have specialized trainings also, like for during the during the COVID time, we had Pally COVID program, which was intended to take train about how to take care of palliative care when the patient is affected in COVID, like with COVID. So that's what Pally COVID was. And we have specialized training for physiotherapists, pulmonologists, and in government, we support training for the CHOs, ASHA workers, ANMs, etc. So that's what we do in capacity building for all these models, for government, for profit, charitable and subsidized model. For opioid availability, we support in getting the NDPS Act implemented. So when I was talking about in the previous slide, I told that NDPS Act is there, an amendment has come, but there are states wherein the implementation is yet to happen. So in that case, we work with the NHMs, the state governments, the drug controllers to get the NDPS Act, which is already in place, to get it implemented in the state as a whole in a state. So we work for that also. And we try getting RMI. Like I told you that you have to be registered, recognized medical institution. So for that also, we help in getting it available and the process involved in getting those RMIs. We are trying to, and with government, we are trying to work with NHM to get the opioids included in the state essential drug list. So there is a essential drug list that is published by government. In that, opioids, in some opioids are not there. That opioid in the sense, opioid which are used for pain relief for palliative care. There are opioids missing from the essential list. So we try to include, we talk to NHM to get these opioids included in the essential drug list. So that's another work that we do. We do hand-holding for the palliative care units at district level, connect them with the local palliative care networks, and we provide assistance for documentation and further support that is required to set up a palliative care unit. We help in developing program implementation plan for the state, implementation of the NPPC, development of palliative care through health and wellness centers under Ayushman Bharat scheme. Palliative India also contributes developing a state palliative care policy, like we have in Kerala. We have a state palliative care policy. So every state should have that. So if a state is not having that, Palliative India tries contributing to develop a state palliative care policy. And for that, we do have regular connect with the Ministry of Health and Family Welfare for developing palliative care in states. We help recruiting human resource for starting a palliative care center. Like in Palliative India, we help the stakeholders to put their ad on our website. We try them find resources who might be trained by us and then looking for a job in palliative care. So we'll be connecting them to, like, the training department, and the state facilitation department gets connected for this matter. So and also we publish the ad which the stakeholder wants to, the vacancy ad on our website. So we get resumes through that too. So that's the facilitation that we do for the recruitment process. And we facilitate the cost management and sustainability. We help in So the arranging fund part, we help in build funds through donation and help in grants and CSR applications. So for charitable and other individuals, this is what is in required, like the grants and the CSR funds. So we help them get that grants. We connect them to any funders that we are aware of who is working in palliative care. So we do that also. We also have a new process in plan. It's called implementation team support, where we send an implementation team of a doctor, a basic unit, a doctor, a nurse, and a coordinator to your site, like in the stakeholder site, and we'll stay there for with you. We'll be hand-holding your team through the process of setting up a palliative care service for a given period of time. So that's what the implementation team does. Any questions till now? Anybody? I'm not boring you, na? Okay, so I'll go forward. Next is the challenges. These are challenges in all sectors that we have faced while helping or while facilitating organizing palliative care service for our stakeholders. So as the four sectors that I have been talking about, that is government, for-profit, sustainable, charitable. So these are the challenges that we have faced. We, in the sense, the regional coordinators that work through all the region around India, they have faced these challenges like availability of funds and human resource. That's a major challenge because palliative care is a new topic as such, and there is a lack of trained resources. So we are finding it difficult to get trained resources for the stakeholder. It's not like the stakeholders is not having trained resources. So we help them get trained resources. But even then, since it with another challenge is that it's not a lucrative business. It's the mindset that we have seen as no treatment or no saving of life is happening in palliative care. So the people are not at all sometimes interested in palliative care. There are people who are very much interested, like Dr. Raj, and taking everything forward and making a Pallium India like this. So there are people like that, but yeah, we have faced such challenges also. Inadequate knowledge in palliative care and amendments that I have mentioned, that we have amendments in place, but there are states who are not aware of. Maybe they are aware, but they are not implementing it by whatsoever reason. So that's the major challenge that happens in all sectors. And with government, it's like no fund. There is a limit. There is fund. There are funds, but they are limited. Like I have heard that it's 1 lakh for palliative care delivery for a state. I don't know what will you get for 1 lakh. So that's what one thing. And same, it's for the medical colleges and no provisions for a palliative care unit in NPPC. It's not a priority in any of the programs. Very in Northeast region that we are our regional coordinator, Northeast face this challenge, like they have limited funds for Northeastern states. So they are interested in palliative care. They want to run a system, but they don't have funds. So that's the major challenge. Now there are communication gap, that Ministry of the Revenue at center and the implementation to be done by the Ministry of State. So center state communication gap is there. Reluctance in collaborating with an NGO, that's one challenge. Then getting an appointment is a challenge. Endless follow-ups are like we have to, it's a government thing, and government is like follow up, and that takes a long duration to find a result out of that follow-ups. And conflicts in interdepartmental hierarchy approvals, that's a major that I think is a major thing in government sector. And one thing is another, it's not mentioned here, I'm not sure if it's mentioned, but in government sector, the transfers are a major challenge. Like I train a doctor in palliative care, the doctor runs the clinic for long and then he gets transferred. Another person comes in, he doesn't want palliative care, and no. So then the palliative care unit is stuck there. So that happens. These are the challenges. So any other challenges that you can think of that can, you know, anything that comes up in your mind, which I have not mentioned.
Hi.
Yeah. Yes, sir.
Yeah, so I have been running a dental clinic for my wife, and I have a plan to start a palliative care center. And the major problems which I face in my locality is the panchayat's permission, the licensing, and all everything getting delayed on their part. Like right now, I have given the application for renewal, but it has been 2 months, 3 months already. So that delay is also a very tiring process.
Yeah.
And if you are supposed to start a new palliative care center, I think you will have to go for getting a pollution control board certificate,
Yes.
image certificate. So it's like a very hectic process. Process itself is very hectic. That's why many people are not very keen in starting center. So I think government should take some action in simplifying the process.
True.
That's from my
So
part.
even now, when we are an established organization, like Pallium India has been working since 2003, we are facing this challenge of getting pollution and image certification and all. So that happens. That's what endless follow-ups mean in one way. So yeah. Another is, in your experience when starting a palliative care unit, what kind of funds are we talking about to start with? Not like for when it's a government. If it's a, you know, if you are a part of government, then you'll have, as I told you, you will have funds from NPPC and Ayushman Bharat for starting a health and wellness center. So there are funds available with the government if you are attached to a government organization, like government hospital. Otherwise, for it's donations, public donations, CSR funds, grants. There are people who fund for palliative care. Yeah, one more challenge that I can now recollect that Dr. Raj always mentions is some of the funders have asked why to support patients who are dying. So that's another challenge that comes up as in looking when we are looking for funders. So, but there are funders who are supporting us. Major part of our work that we do here in Pallium India is supported by public donations, general donations, the individual donations from the individuals in and around India, and few from FCRA funds. There are grants that are being supported for, you know, through which we are getting our salaries supported. So we are working like that. So maybe you can try some grants or CSR funds.
Another, I'm Dr. Nari speaking.
Yes, ma'am.
Another challenge that I think we're facing right now is because of the human resources crunch.
Yeah.
So there are very few of us. So to divide our time, whether to do look after ICU, look after OT, look after palliative care. So it becomes really difficult because we have to stretch ourselves really thinned out to manage so many areas. So most of the time people would want us to focus, on the surgeries, the OTs and the ICUs, because a lot of people don't have much idea about palliative care and how much that it's really required.
Yes. So that's what we should have a dedicated separate team for palliative care, I suppose. That's what
I would like to add a point to what Madam has just told. So this human resources, actually coming to that point, we always have to do multitasking. That is from my point of view. There is nothing like an anesthesiologist doing only anesthesia. I manage critical care, I manage anesthesia, I do clinical trials, and I also now I am planning to open up a palliative care center. So we have to come up because we are the capable part of the society who can help others. So we have to come up with a strategy in multitasking. So I think that empowering our colleagues is a way to reduce our stress. Even nursing staff, if you can train him to intubate, then your stress will be half reduced. You don't have to run around at night, like get a car and go to the hospital just to do an intubation. So empowering people around you in every aspect is a very useful thing in that matter. So I do that. I usually do that. Even I have some people who have given even the signature authority. They sign for me. So like that things we can do. So I don't have to be there every time 24/7 to get papers signed or moving things. So I think we can empower people around us to do half of our work.
Yeah, that's true. Anything else, or shall we move forward?
In the chat box, there's a question about how to get license for morphine for a hospital. Same thing. I also have a concern regarding if I'm starting a palliative care center, how am I supposed to proceed to get a license for that?
We'll come back to these questions at the last because it's a detailed thing. So we'll answer those questions in the last. So now this is kind of a self-evaluation audit tool for palliative care centers to know where we are standing as a palliative care unit. So there are two parts, part A and part B. Part A is essential, which is the minimum requirement to that a center should abide. And the ones listed in the desirable are the regular requirements. So there is a link in the bottom. So that will take you to the original document. So this will be shared as a learning material to you. So you can click on that link and get access to the original document. Like this is just a screenshot that I have shared here. So you can go through each thing, and it's never always linear scale marking. So these are the things that are required. The essential things are which are required for a palliative care center to run. So if you are, when you scale it yourself for your organization, you can see where you are standing. So based on that, you can work upon your organization, and then like what I told, it's a self-evaluating tool for your organization. So it might be difficult for you to see here. So when you get the learning material, you can go through the PDF, the original PDF that the document is. It's a 3-page document. So you can go through that. Next, now, as I told you, like the Kerala model, almost Pallium India is like that. So community charitable model is the model that Pallium India follows. So we are a charitable trust. We formed in 2003. It's 18 years now, and like we are the work model that we are working is demonstrate, educate, and facilitate. It's called DEF model. Wherein demonstrate is the thing that we do here in Trivandrum. So we have Trivandrum Institute of Palliative Sciences. That's the organ which is operating in Trivandrum. We have link centers, OPDs in hospitals, like I mentioned before, that we have OPDs in the Government Medical College. We have OPDs at SAT, the pediatric palliative care clinic OP is running at SAT hospital. We have OPDs at various link centers. Now, the link centers are centers that are catalyzed by Palliative India through community volunteers. So we call them link centers. It's not these are the terms given by Palliative India. So in link centers, it happens like how link centers originate is we create awareness. We give awareness session in the community. Maybe a community we have identified that there is a need of palliative care there. We go and give awareness sessions. We do sensitization programs wherein public of that area will be coming in. Maybe the residents association people, the clubs, the Lions Club, the Notary Club, and etc. The representative from that clubs or the representative of the area, they come up. After the session, we find that few people are interested to work in palliative care. They form a group, like local champions are now found out. They form a group. They register their group as a society or maybe a trust in future. First, they'll start with the registration as a society, and then they'll act as a link center for Palliative India. So another small Palliative India in a rural area or maybe an urban area, whatever, the area where we created, where we did the awareness program. So these are the areas wherein palliative care is very much required. So it will be a vast area. These community volunteers whom we have identified will be identifying patients from the community. So the referrals will be coming from there. So we'll be conducting outpatient units in these areas. So like what I mentioned earlier, that for an OP, we just need a classroom or a hall or something like that. So these link center volunteers will be arranging for a space where we can conduct OP. A team from Palliative India, a doctor, a nurse, and a social worker goes to these area, these hall. We conduct OP there. We'll be taking all medicines with us. Maybe at the OP, only the patient who can walk by their own comes in. For others who cannot walk, who are bedridden, for them we conduct home care. So that's how home care works. That's also link center home care. So a patient is identified by the volunteers. These volunteers come along with our team. They go and show the space, the house, their houses. They come with us. They brief what the patient is undergoing, and then we connect them. So that's how we get in connect with the patients. Hope you got the connection. Right. That's how I am touching upon many aspects, like palliative care unit going, the meso component getting involved, the macro getting delivered at the micro level. So many aspects are coming in. So all those things that we have learned till now is coming into practice right now here. So that's how it works. So link center OPDs are not only conducted at various link centers. We have OPs, like I told you, we have OPs at government hospitals. So it's an established hospital and we have a room there, a dedicated department for palliative care. So in Trivandrum Medical College, we conduct OP on every day except for Sundays, from 1 p.m. to 4 p.m. So this time is dedicated for palliative care. So referrals, we get referrals from entire hospital, or those who are not able to come to our OP here in Palliative India, they are referred to these centers. So that's how it works. Any questions? So here the community engagement part comes in. Hope you got the link. This is how Palliative India works. the tips model works, the demonstration model works. So now this is what Palliative India does here. We have an inpatient care unit. Now TIPS is a WHO collaborating center for training and policy for access to pain relief. So that's a WHO collaborating center. We are a training institute, and along with that, we conduct patient care also through inpatient care, outpatient unit, home care. Now the rehabilitation and reintegration. This is we have a halfway home project running at Palliative India. So that we call it as halfway home. For us, it's a halfway home. It is a rehabilitation project. It was it was funded by Social Justice Department of Kerala, Government of Kerala. They supported us for 3 years, and after that, we took it as our project. So now we don't have any funding for that. So here it's like it's the rehabilitation of patients who have spinal cord injury. So people with spinal cord injury are admitted here, and they are trained on how to be independent. Like, don't depend on others for your daily routines or something like that. So this area, the halfway home area, is a wheelchair friendly area wherein a patient can direct himself by himself. He doesn't need any support from his caregiver, and the things are very the accessible for him. By sitting in the wheelchair itself, he can access everything that he wants, and he can. So here we trained him for roaming around on his wheelchair and getting transferred himself from the bed to the wheelchair and vice versa. Like, so we trained him. Also, we have regular physiotherapies going on so that some mobility is recovered. So that's what we do here. It's not that we promise him that your mobility will come back. No, we just help him to live the way he is, and we help we help him do like we train him. We with vocational rehab, like that's called vocational rehabilitation, where we train him to earn his living. Like, for example, we have done training for umbrella making, soap making, jewelry making. For some, we have done catering training. So some 3 chefs we have from halfway home. So that's how with that they earn their living. So that's how it happens. So that's what happens in the rehabilitation and reintegration. It's not for the patient who are in halfway home. This is done for each and every patient who is registered with us, where we feel that rehabilitation will make a change in his life. He or she don't feel like he or she is dependent on somebody else because of his illness. That's what we try to help them with. Now, community participation is already, we have discussed that. Halfway home also supporting this is what I mentioned right now. Till date, we have touched 21,000 plus. This is counting patients and families in Trivandrum. And the link centers that I was talking about, we have 14 link centers and 87 volunteers who are dedicatedly working for link centers. We have few other programs also, which are not mentioned here. Like, if you have gone through the introduction to palliative care session, there are 4 aspects that are taken care of in palliative care. So physical is taken care by the medical team. The other things, the social aspect, the spiritual aspect, and everything, emotional aspect, this is taken care by volunteers as well as social officers who work with us. So here comes the rehabilitation, wherein we provide vocational rehabilitation, we provide physical rehabilitation, we provide in physical we provide wheelchair, physical aids, everything. We provide food kits. Like the food kit aspect came into picture when whenever a doctor prescribes medicine, he or she tells the patient that have it after food. So now a patient came to us with all the medicine we had given him, and told that I haven't had medicines because I don't have food, because you told to have it after food. I don't have food at my home, so haven't have medicine. So with that thing, we started giving food kits, wherein we have every month on the first week we have food kits which has regular ration, which is based on their diet plan. So every patient has a diet plan. So there are kits customized as per his diet plan, and we provide him every month. So we provide around 80 to 100 food kits every month. We provide education support to the children of our patients. These are all based on the assessments that's done by the social officer. So there are procedures following it. So whenever if you have, whenever you feel like you want to visit Palliative India, just let us know. I will be happy to have you here and show all these things that we are doing, trying to make sufferings less. So you can come and visit us. This is what I can explain you verbally right now here. If you come over here, you can see it happening here. So next, this is the national helpline called telehealth. This came into action during the COVID times. So during the COVID, we weren't able to go to patient because of the restrictions that we had here. So we started this telephone, this phone IVR, through which patients as well as medical professionals call us. Medical professionals are calling us for the advice of how to manage pain and how to do palliative care. Maybe they are finding it difficult for some patients. Some may find it difficult to procure opioids during these times due to the logistical problems. So that have happened. And patients from anywhere in India are able to call on this number for any palliative care need that they want. We also try to provide emotional support through this helpline. So this is the number that can be used for telehealth consultation for palliative care. It is free of cost, Monday to Saturday, 9 a.m. to 4 p.m. So that's what telehealth helpline is. Now coming to the next phase, the E phase, the educate thing. That's what we are doing right now here. We educate doctors, nurses, allied medical professionals. Specialist trainings happen, like for pharmacists, pulmonologists, like I told you before. So these are the courses that we currently have at Palliative India. So for doctors, it's a foundation course in palliative medicine. It's like we have on-site programs also. We have virtual program also. This is a virtual program. On-site, we have CCPM, Certificate Course in Palliative Medicine, which is a 6 weeks course for doctors as well as nurses, as well as CCPC, which is for allied healthcare professionals. That happens on site. These training sessions can be done at your end also, if you are interested, or if you can find any group of people who are interested to get themselves trained in palliative care. We can do it at your end also. That's what the on-site training program that we do for other sites, not at Trivandrum. We do it for other states also, other states or other sites. We have student training for student volunteers. It's called SAN Spain. We have training for palliative care beneficiaries. It's called Arohan, wherein lived experience are shared amongst the participants. So that's the group of people who attend the Arohan program. RCPM is a specialist program wherein after this training, you get experience in palliative care, and there is a refresher program for doctors. So that's RCPM. Next, coming to the facilitation part, this is the tier where I come from. So this is the work that state facilitation team does. We have the philosophy of state facilitation division is to integrate palliative care in all the 3 levels of healthcare: primary, secondary, tertiary. So as I mentioned earlier, we have 4 regional coordinators at 4 different regions. North, we have Rajendra, who is based in Uttarakhand, and he looks after the northern region. Northeast, we have Rontu Sangma. He is based in Guwahati, and he looks after the northeastern part, specifically the Seven Sisters and West Bengal. Central, we have Sunanda. She looks after the central region. And south, we have Vishnu, who takes care of the states in the south region. We shall share the contact details of all the coordinators through the chat box, and you can get in touch with them for any region-specific queries or facilitation. So all the facilitation that I mentioned before, that we are doing this things, for any queries based on your region-specific, I'll show the map wherein you will be able to see where all these regional coordinators are working. So based on that, you can get in touch with each of them, and we'll take it forward. So, and I work as national coordinator. I coordinate with these regional coordinators, and we have a head facilitation, Shalini, who is heading the state facilitation division. So that's a brief on what state facilitation team looks like. Now, the 5 objectives that you can see here that drive state facilitation division are catalyzing new palliative care centers and services, government, charitable, sustainable, and for-profit model. We help in end-to-end facilitation for catalyzing centers across these categories. So end-to-end facilitation means starting, like we saw the 10-step approach, starting from arranging funds to getting the involvement of volunteers, the 10 steps. We help you in facilitating these all things. So wherever you get stuck, we are happy to help you. Please just give us a call. We'll be talking to you for after your course ends. We'll be getting in touch with you. But in case, meanwhile, if you feel that you have some doubts in arranging these things, like we had a, I remember the person who asked me that he is Anish, I think. Yeah, Dr. Anish. So like that, if there are any such queries, we are there to help you. We are the team who will be facilitating these things to you, these things for you. Next is assisting opioid in opioid accessibility. We assist in opioid accessibility by facilitating in getting the RMI, getting certified as RMI institutes. There's a long procedure that is involved. That's what one query was about. So it's a very long procedure. Getting RMI certified is a very long procedure. There is a session called opioid availability session, which will be taken, I think, in further, I don't know when is it planned. So there is a schedule for that. So you'll be having a session purely on how to get yourself certified and what all documents are required, what all things you have to take care of to get yourself certified as an RMI. And after getting RMI certified, what all documentations you have to do is, it will be a full-on session planned for you. So there is a plan, session plan. So you'll get all the information through that session. And meanwhile, if you feel you want, no, I don't want to wait until the opioid workshop and I want to apply for an RMI, please get in touch with the regional coordinators whose numbers have been shared. So we are happy to help you on that. Next is we enable palliative care learning in the medical institute. As we know that the education plays a major role in delivering palliative care, we try to work with the medical institutes to involve palliative care in their undergraduate curriculum for doctors. So here we work with the trainers, then they in turn train the students in palliative care. So that's what happens in the faculty, we call it a faculty development program. So that's what happens in palliative care learning with the medical institutes. Now we work with the stake. Sorry, somebody spoke. Okay. We work with the stakeholders to help them build the community engagement and help them mobilize the volunteers. So here in Pallium India, we create awareness among the public. That's what I mentioned earlier, that how the link centers get formed. We create awareness among the public, get similar interest people together, then they form a group as link centers, and then they take the ownership. That's what the important part is. They take the ownership of taking palliative care across their region. That's what the important aspect is. The ownership is taken by the community volunteers. It's not with Pallium India going and taking care of the patient. It's the community that goes and takes care of the patient needs. We just facilitate. That's what Pallium India does as a whole. We just facilitate. These community link centers will then be a sustainable model. Until and unless they get self-sustained, we do help them. But yeah, when the moment they get sustained, we pull ourselves back and we go and look for other link center, other interested people. That's what happens in the link center model. So these link centers will be having a doctor, a nurse, a social officer, the basic unit. They'll be hiring people. At their end, they'll be doing care. So we'll be visiting once in a week. So continuous care is being ensured by these volunteers. That's what community engagement means. So we'll be training them for that. Now, developing pain-free hospitals. That's this objective is in a budding state right now. We are trying to develop a hospital wherein any patient that enters for treatment is assessed or treated by the pain score that he has. So the pain score is measured by the scale, which ranges from 1 to 10, 10 being the highest. So that's how a pain-free hospital is developed. Any patient entering into the system is assessed by the pain that he has. So based on the pain, the treatment will be made available to the patient. Now, with all the facilitation that we do at Pallium India, before that, I'll show you the map wherein our regional coordinators are working. This is the place where regional coordinator, North region works and Northeast. So Ron and Rajendra. So you can go through and see which regional coordinator you will have to contact for your queries or for your hand-holding. So these are the states that these regional coordinators handle. Next is this central, it's handled by Sunanda. South is handled by Vishnu. You have their numbers. These are the states handled by them. You are free to handle, or you are free to contact them for any facilitations. And I, being national coordinator, I'm also available for any of your queries. So feel free to contact me as well. Now, this is the national presence of Pallium India as on date. So we have worked with NHM, state governments, state drug controllers for training and facilitation. So we have worked with 25 states and 3 union territories. We have catalyzed 5 training centers, one being Trivandrum Institute of Palliative Sciences. Another is MNJ Hyderabad, GCRI Ahmedabad, BHCHRC Jaipur, and PSG Medical College Coimbatore. These are the training centers catalyzed by us. Coimbatore is still in, a budding state, so it's not a full-fledged training center right now, but the rest of them are. We have done on foundation training, on-site foundation training that I was talking about. Like we do training at the sites where the stakeholder is. If they have a group of people who are looking for training, we'll go there and do the on-site training. We have done that for 10 sites. We have 2 pain-free hospitals right now, the 2 small hearts, and we want India full of hearts. That's what our aim is. That's why we have kept it as hearts. We have done 6 faculty development programs. We have catalyzed in the sense end-to-end that I was mentioning about previously. End-to-end facilitation is done by us for the 64 sites. We have Hamrahi sites. Hamrahi is a project wherein we are working with APLI, Australasian Palliative Link International. It's for mentoring palliative care centers across India. As of today, the mentors of APLI have mentored 28 sites through this project. So it's a mentor-mentee program that happens through Hamrahi project. Hands-on training is like while you are having a virtual training, with the theoretic knowledge, you may not be able to do, open a palliative care center unless you have a hands-on experience. So as and when after the virtual training, after the theoretical part, you will be shared with a list of hands-on training sites that we have. Based on the list, you can, choose any of the centers that is, nearby your area. You can go there, have an hands-on exposure, and then you can start a palliative care center. Without practical knowledge, it's very difficult for us to, get into palliative care. So hands-on training is helpful for that. So we have 40 sites. You are not required to come at Trivandrum for getting hands-on exposure. You can get hands-on exposure any of the 40 sites that you can see in our map. So this will be shared by the training team after you complete your training here. Next is opioid access facility. These are 9 sites for which we have done support to get them registered as RMI Institute, like certified RMI centers. So this is for this year. These numbers are for this year. So this year we have facilitated 9 sites in India for getting RMI certification. Thank you. So
thank you so much, Ms. Arathy. I believe that was a very huge round of information for every one of you out there. The chat box, the overflooding chat box itself says things. Now I would request maybe Mr. Vishnu, who is accompanying us today here, to provide some clarifications regarding the queries in the chat box. Vishnu, would you like to take over for the moment?
Thank you, Supriya. Good evening, all. My name is Vishnu. As Arathy said, I am also part of the state facilitation division here. I'm working as the regional coordinator for South Indian states. So I'll try my best to answer all the questions. So I think the first question is, what does complete palliative care center or unit consist of? Basically, it depends upon our requirement. For a basic outpatient facility, we'll have an OP examination room, an opioid. If you are using opioids, basically pain relief and pain relief drugs are an integral component of palliative care. So if you're using opioids, then you must have a opioid safe locker, a double locking system. If you are having an established institution, then you must have a separate dedicated opioid locker room for stocking the opioids. And as Arathy mentioned, a disabled-friendly washroom was also required. So all these are depending upon your requirement. If you are starting on a very low profile, like a basic entity, to then a basic examination room is more than enough with a basic furniture, an examination couch, and a disabled-friendly infrastructure. That's more than enough. Then what's the yeah?
One second.
Yeah.
I put up my hand, but I guess it's not showing. So if we already have a functioning this thing, what you say, OT. So we have the anesthesia drugs there in double locker. So then there is no need of keeping separate, because actually we'll have to move it from the OT to the what you say, the OPD where we see the patients.
Yes.
So is any other security, or at the end of the day, if you write the count is enough?
Yes. Basically, two things are here, ma'am. That's actually answer for the other question, to procedure of getting opioids for a hospital. So as per the new NDPS Amendment Act, we have to obtain a recognized medical institution certificate from the State Drug Control Office for using...
We are a recognized institution.
Okay.
We are a recognized institution. We are talking about IBHAS, especially in Delhi. So I am in the Department of Anesthesia currently, and then I will be in this department.
Okay.
So what we're planning to do is, anyway, the institute has license for morphine. Right now we're getting the 4 rupees vials, and we're using it very sparingly for just those few patients that we have assigned palliation for.
Okay.
So I'm just asking you whether now that we'll start getting dispensing the tablets, so we can use the same double lock which is under sister's care?
Yes, if we have a double locking facility, that's more than enough, ensuring the proper documentation according to the new RMI thing.
Because anyway, we are doing fentanyl and we are doing morphine vials.
Understood.
Only now we'll have to add tablets to it.
Yes.
So we'll have to procure the tablet form.
Yes.
I need some more additional help.
Sure,
I have sent madam my number and my name. If you can please contact me back at your
ma'am.
time.
We'll ask our regional coordinator North, Mr. Rajendra Bajalwan, to contact within a half an hour. He'll be calling you.
Thank you so much. Yeah.
So just an update regarding procuring, I think Dr. Anish also asked this. So regarding this, as per the NDPS New Amendment Act, every organization who are using this essential narcotic drugs, a total of 6 drugs has been notified, but 3 drugs are available in our market: morphine, phenylephrine, and methadone in all formulation. If a palliative care entity or a hospital should use these drugs for medical purpose, then they need to apply for an recognized medical institution certificate. There is a whole list of forms available. You have a separate session for that. So along with a cover letter, with a 3J form and a 3F form. The 3F form is the application form for the RMI. So each state will have a dedicated drug controller who will be the nodal authority for issuing this RMI certificate to that particular entity. So that entity has to apply for the RMI to the corresponding state drug controller's office. Union territories will have a dedicated drug controller office, or will be connected to the neighboring or the corresponding allocated state. So the eligibility criteria for applying for the RMI as a lead palliative care physician, there are 2 eligibility criteria. Either they should have an MBBS or a BDS degree, and they should have completed a certified course in palliative care. So these are the 2 eligibility criteria of a lead doctor who will be the signing authority for that RMI institution. And there are a couple of documents to be ensured within that entity. along with the RMI certificate. So as Arathy mentioned, this is a long process. Most of the institutions are not aware about the new NDPS amendment happened in 2015. Before the amendment came, it was a complex process going to Excise Department, Health Department, Police Department to get the licenses, transport and import permits. So now it has been eased. Only the state drug controllers are the nodal authority to issue this RMI certificate and regulate the purchase, stocking, and dispensing of essential narcotic drugs for clinical purposes. So it will be taken in more detail on the opioid availability session. So is it possible to visit a center? Yes, and a halfway home. You can schedule an appointment with our regional coordinators. We'll have a separate dedicated schedule for you for a week as an observer here in our headquarters or tip center. In halfway home also, you will get to have a good exposure. Just to get in touch with our regional coordinator. It has been shared in our chat box. So corresponding to the region, or don't just focus on the region. You have a number, just call. All the numbers are available in our website also. We'll schedule a separate chart for your visit here. What would qualify for RMI? So yeah, recognized medical institution is an entity, is a name given as per the new NDPS rules 2015. If an institution or a hospital or a palliative care NGO is using essential narcotic drugs, so irrespective of palliative care or any other department, if that institution is planning to use or dispense essential narcotic drugs, mainly morphine, methadone, and fentanyl, any formulation, then they have to apply to the state drug controller office for getting an RMI certificate, that is recognized medical institution. With that certificate should be displayed on the that premises. Only then they have the that certificate makes that institution legally eligible for purchasing, stocking, and dispensing these drugs for medical purposes. So that's the ideal definition for RMI. So I'm not seeing any other questions in chat box. All are listed. So any other questions? How long will, okay. So one thing actually we due to this is a separate topic. We are not going to in detail. So how long it will get the license for a government medical college? All the government institution, government hospital, government medical colleges are deemed RMI. They don't want to apply for an RMI certificate. They even though they don't want to apply for an RMI certificate, they need to ensure the proper documentation as per the rule of NDPS. If a drug controller or his representative came for an inspection, that institution and the authorities are supposed to show them the records of the opioids. All the government institutions are deemed RMI. They don't want to apply for a recognized medical institution. Yes, OP private clinic can also apply for RMI, provided you need to have, as I said, if it is a small setup, you should have an opioid safe box there, a double locking facility. There are specifications we can support you in purchasing that lock box. Then you need to ensure the proper documentation. And of course, you need to have a signing authority, a lead palliative care physician or a lead doctor who is trained, who has undergone or trained certificate course in palliative care. Can we refer? Definitely, you can do that. You can contact our regional coordinators itself. They'll refer them to the clinical division here, and the patient can get admitted here. If you have any more questions,
excuse me, Vishnu.
Yeah.
One doubt.
Sure.
Yeah. So I was planning to start a palliative care center, and
Okay.
two things. One, I am working in a hospital where morphine, even tablets and patch is also available.
Yes.
And
Your voice is breaking, sir. Can you type in chat box?
Can we?
Still, it's breaking, sir. So still, it's breaking. I think your network issue. I'll do one thing, sir. We'll contact you after this training program.
A consultation at home, which is like basically a clinic. So if I must type it, right? So, see, I just want to ask that, but briefly, I will ask. If a person having consulting at home, okay, I'll.
So sorry, sir. I think we lost you. Sir, we'll connect you. I'll call you right away, sir. Where we source the morphine and other opioids by the local vendors. Once you receive the RMI certificate from the drugs controller, along with the annual requirement of the annual estimate of the opioids and with the RMI certificate, you can place the order, a purchase order with the local vendor, and they can issue the opioids to you. So you will have a consignment letter issued. You should have to sign a couple of documents. So it's that's what this is a long process in the opioid availability session. You will get to know more. And if you can go through our Palliative India's website, there is a link provided to all the required RMI documents to be ensured. You can have just a look and you will get a more idea on the next session, opioid availability session. So I think.
Okay, thank you, Mr. Vishnu, for answering those queries. As of course, as usual, our team is open to more queries, more questions regarding this topic. You can either mail to us, WhatsApp to us, and you already have our coordinators' numbers. Please do get in touch with them as well. I think we have one last question from Dr. Anish.
Yes, Dr. Anish, we can do that if you can prescribe opioids from home consultation. If you can register your patients with Palliative India, then definitely we can courier that medicine to the patient address. That can be done from our side. For a government medical, I would like to know how to source. We already have a certified person. Yes, ma'am. May I know from which region you are? We can connect with the regional coordinator there.
Dr. Indiprabha Yasavi is from Trivandrum itself, I guess. Sir, okay. If you could unmute yourself and. So you are muted.
Hello?
Yes, sir.
At present, I am at Palliative Medical College.
Oh, it's you from my region, sir.
I was at Trivandrum, but at present I am at Palliative. We have a certified person there. I was talking about this today with him. He told me we need a license like that. That was why I asked the question.
Yes, sir. Actually, we need to apply for the RMI certificate. After that, we have local vendors there. And from Cochin also, we can purchase the opioids.
But being a medical college, it is.
You don't want to apply for the RMI, but we need to ensure the documentation.
Okay. Okay, I'll call you back.
Okay. Sure, sir. We'll be in touch. Okay. Is FCPM option for registration as RMI? Yes. During COVID time, Kerala State Drug Control has issued a separate circular that even online training like FCPM, structured course and palliative care, those participants are eligible to apply for RMI. With this circular itself, I think Uttarakhand government drug controller also has issued that this online training is good enough to go and apply for RMI. So yes, that's we got an official confirmation from State Drugs Controller during COVID. So yes, FCPM is sufficient for applying for RMI registration.
Okay. So any other last questions we can take in before we wind up for the day? Okay, I believe that most of your queries have been answered, and as I told, you can definitely get in touch with us again. So with that note, this is Sri Priya along with Ms. Arathy, Venukumar and Mr. Vishnu PR signing off from the Tips Eco Hub for the day. See you in the next session. Till then, everyone, take care. Bye-bye.